Lupus is a chronic inflammatory disease that can either be systemic or restricted to the skin, whereby our immune system attacks our tissues. In fact, lupus impacts the lives of close to 1.5 million Americans, with close to 5 million people worldwide. About 10% of all lupus cases are cutaneous, with 65% of people with systemic lupus also developing manifestations of lupus on their skin. Today, we have the pleasure of welcoming Dr. Victoria Werth, a world renowned expert on cutaneous lupus. Dr. Werth is a professor of dermatology at the University of Pennsylvania School of Medicine and serves as a chief of dermatology at the Philadelphia Veterans Administration Hospital. She is also the co founder of the Rheumatologic Dermatology Society. Her long standing interest in clinical and translational research pertaining to cutaneous lupus erythematous have developed to propel our understanding of how to diagnose and better treat this crippling disease. Dr. Werth, welcome and thank you for taking the time to speak to me today.
It's good to talk to you.
So, I first want to start off by asking you, what is lupus?
Wow, that's a big question. So lupus is really a spectrum disease with, I think, quite a number of different genetics and environmental type triggers. And the spectrum includes patients who, as you mentioned, have only cutaneous lupus, which are actually probably more than 10%, probably, close to maybe even 30% or so. I mean, it's not an insignificant number, and there's some studies it's been almost equal numbers of CLE and SLE. And then on the opposite end of the spectrum would be systemic lupus with people who have, systemic disease, no skin, and there's a lot of people in the middle. And so what it is a disease where there are some genetic predispositions, as well as things like ultraviolet light that can be triggers, certain medications. It's quite heterogeneous in terms of the pathways and cells that are activated in the skin, for instance. And so it's really not just one disease.
Is there a specific physiology behind lupus? I understand that, it could be drug triggering or have other triggers, but what is the main physiology at this point that we understand for lupus?
Yeah, so essentially there are inflammatory cells. If you take a biopsy of skin, you see inflammatory cells at the dermal epidermal junction. They tend to be a mix of cells, but very frequently lymphocytes, either particularly CD4s, but also CD8s, and they're at the interface, but also around hair follicles and around vessels in the skin. And so there is a pathology that is called interface dermatitis, which is pretty also seeing changes in the epidermis, where there's vacuolar change in some of the basal keratinocytes, so it's a reaction pattern that can be seen not just in lupus but other autoimmune diseases. So part of what one has to do is to differentiate between several different autoimmune diseases when you get that pathology back.
That's very helpful. So, for many patients, I understand that sun can play a big role in development of exacerbation of the skin lesions. What is the pathophysiology behind that? I know that many of these lupus patients are photosensitive.
Yeah, so I mean, again, not 100% known, but there are a lot of cells that can be altered in the setting of UV. And they can be, keratinocytes are activated. There are a number of pathways that are activated with UV. You get production of a number of different pro-inflammatory cytokines, which are likely, including type 1 interferons and type 3 interferons, that probably bring in cells to the dermal epidermal junction. And then there's a whole crosstalk between these inflammatory cells and the epidermis that sustains these reactions.
How do you go about classifying acute versus subacute and chronic cutaneous lupus?
So that's basically meant to be different clinical subsets of cutaneous lupus. And so, if you have a butterfly rash with erythema, that's more acute cutaneous. And typically, those patients have a high likelihood of having systemic lupus. Subacute cutaneous lupus has a different morphology. Really, all of these typically have different morphologies, and subacute cutaneous lupus either looks a little bit like psoriasis, or it can look like annular polycyclic lesions. And then discoid is more erythematous lesions. There can be some follicular plugging, and then they can resolve with scarring. And really, any of these can cause pigmentary abnormalities as they heal. And then many times, maybe 20% of patients have more than one subtype, or you can't tell the subtype at the beginning. And so, these are working kind of classifications, but they're subject to change as well within a given individual.
So someone might have a butterfly rash, but also show signs of, say, discoid lupus. And so you can't really put someone always into one subset.
Correct. And that happens about 20% of the time. And that doesn't surprise us, but it basically means that when you go to diagnose people, you have to sort of know that there might be more than one morphology of lesion.
How do hormonal factors influence susceptibility to lupus?
Right. So we know that women are more prone to getting lupus, although that hormonal contribution is probably a little bit less in cutaneous lupus and in systemic lupus. It turns out that men also get cutaneous lupus at a higher rate than they do systemic lupus. And basically, there are likely to be genes that are part of the immune response that are regulated hormonally that are causing problems and causing a predisposition to lupus.
So, do you see an uptick in lupus during pregnancy?
So it's usually more at there are different times that lupus kind of happens. One of them is during in adolescence, in younger people. Pregnancy is not a typical one where you see a huge amount of triggering, although we always say that people should be controlled when they go into pregnancy, because if not, then they do sometimes experience flares. And then there's a group that sometimes get them, especially certain like subacute cutaneous lupus, more later in even going through menopause.
And are you ever hesitant about starting treatment while a patient is pregnant and either has their first episode of lupus or they're flaring with lupus at that time?
So it really depends on how they're flaring. So the organ that's involved, has to be looked into, and so people can have a skin flare, but also a renal flare. And in general, they should be treated according to which organs are involved and the severity. There are several drugs that are quite safe to use in pregnancy, and very often we actually want to get people on drugs to stabilize their lupus before they get pregnant, but we can also start them when they're pregnant.
What are the typical risk factors for SLE?
A lot of it relates to genetics, and family history is a risk factor in particular, and depends a little bit on which subset you're dealing with. We know, for instance, that African Americans and some Hispanics have a higher incidence of having CLE and SLE, or having more severe disease, and so that certainly there are contributions in terms of the background of the patient, which is also partly the genetics. And then other risk factors, if people are smokers, that's a problem. If they're on certain medications that are prone to inducing lupus, that's a problem. And so, those are some of the risk factors.
What is the connection of smoking with lupus? I understand that many times if a patient is a smoker, and you're starting them on treatment, you often encourage them to stop. So do we understand the connection here?
I would say we don't. It used to be thought that it somehow interfered with the how well the drugs work, like hydroxychloroquine and so on. But we've done studies that have basically shown that the correlation is not so much about response to therapy and more about the smoking itself. And so there's probably something about the mechanism that's triggered with smoking that is increasing risk. And that's still an area of active investigation. I don't think that we 100% know that.
Do you spend a lot of time educating your patients on stopping to smoke?
So, yeah, I mean, it's a really important part of management. It's the first to try to get people to stop. And I find that I have been successful, but by virtue of having data to show people that they're at increased risk of getting lupus and it's more severe when they smoke. And they often will want to know, well, what can I do or what can I take to help, get rid of this lupus? So it's kind of, a no-brainer to mention that it would be helpful if they could stop smoking. And there are some very highly motivated people that are able to do that, and I certainly encourage them. But there are others that absolutely will not stop. And so, yes, but it's definitely a part of what we do in terms of management.
Have you seen a patient come in and they're experiencing lupus and you ever say like, you know what, the first step, let's see if you can stop smoking. And then maybe that patient is someone who takes on the responsibility of stopping. And then you start to see like immediate or eventually a decrease in their lupus without further treatment.
Yeah, I don't think anyone's been able to do that. Usually, if someone's got lupus that's bad enough to bring them in, they're going to want treatment and not wait to see whether or not stopping smoking is going to help. So it's a great idea, but I don't think we have really good data on that.
And what are your thoughts on the role epigenetics plays with lupus?
Well, we know it plays a large role. I mean, there are the families of people who have autoimmune disease, or often there'll be more than one family member that has some, like lupus or some other related autoimmune disease. It plays a huge factor, but it's a combination of the genetics and then the triggers.
So, can you talk a little bit about molecular mimicry and the pathogenesis of developing lupus?
I mean, I think that there's concern that there may be certain viruses or that could be actually cause infections that trigger lupus, and I don't know that that's totally molecular mimicry. I don't know that we know as much as we need to know about how well associated molecular mimicry is with pathogenesis. Yeah.
Okay. So, do we understand at this point? I did some reading and it was saying that we SLE only targets specific organs, for instance, skin, joints, pulmonary, renal, brain. But supposedly the autoantibodies are non-organ specific. So why is it that we have these autoantibodies that are targeting really only specific organs that we connect with the lupus diagnosis?
Right. I mean, it's a great question. And I think each of the antibodies are a little bit different. If you look at, something like anti-SSA or Rho and LA, I mean, we know that those are intracellular antigens that can basically translocate, for instance, with UV exposure, and then you get antibodies binding at the keratinocyte membrane, and you can see actually speckled immunofluorescence there. With ANAs, I mean, or double-stranded DNA, we know double-stranded DNA, for instance, correlates more with renal disease, and we know complement plays a role. And there's a thought that immune complexes are probably part of that whole pathogenesis. Although that may be true in glomerular disease, but there are other forms of renal disease that are maybe non-glomerular where it's less clear. So even in the kidneys, it's heterogeneous. And I would say that we don't 100% know how these antibodies are working or why certain organs are targeted. But it's a combination of perhaps, like with SSA, the antibodies are binding in the epidermis and triggering a photosensitive kind of response. And that's likely similar kinds of things, and immune complexes are playing a role in other parts of the body.
Do you often see a patient who has lupus as well as psoriasis or other autoimmune diseases?
Yeah, I mean, that can definitely happen. And there definitely is increased thyroid disease, for instance, in people who have lupus. Occasionally they'll get an overlap with another autoimmune disease like dermatomyositis. There are other diseases that definitely are rheumatoid arthritis, Sjogren's, usually secondary to the underlying condition like lupus. But yeah, there can be other diseases that are also seen in lupus patients. It's not all the patients, it's a subset of them.
So, from working in clinical practice and seeing patients, I know that SLE and CLE can often be misdiagnosed with other diagnostic entities like eczema or rosacea, drug-induced photosensitivity. Do you think that this leads you to have a lower threshold for biopsying if you're like unsure, like they don't have the butterfly rash or they don't have the obvious signs and it's kind of overlapping with a different presentation?
Oh yeah. No, I think it's really helpful to get a biopsy when possible on patients because you're committing them to some lifelong, monitoring or medications, and you want to make sure you're not missing the diagnosis. And patients do get misdiagnosed. So it's important, I think, to do biopsies. Sometimes with patients who have more systemic lupus and more acute LE with a malar rash, the patients maybe don't need a biopsy because there's enough else going on that helps make the diagnosis. But even in some SLE, they might get rosacea or get other conditions that you really want to know about. So yeah, biopsies definitely play a role.
Can you explain to me why some patients with systemic lupus go on to develop cutaneous lesions or cutaneous lupus when their initial diagnosis was systemic?
You're right. I mean, I don't think we 100% know why the disease changes. I mean, some people start out with skin and then all of a sudden they get renal disease. It's sort of the reverse direction. I mean, I think we really don't understand all the predisposing factors for why people evolve from SLE to CLE. There may be a trigger that happens in the right genetics, so potentially it could be UV exposure suddenly is a trigger, or it could be a new medication, or it could be even an immunomodulatory approach that somehow is knocking out cells that you need in order not to get the cutaneous lupus. And all of these have been seen.
How do you go about treating patients who come to you for lesions on their scalp, like say discoid lupus of the scalp? What is your go-to protocol for treating that?
Well, it depends a little bit on whether it's active or just more damage. If there's not erythema in scale and it's not active, then you might not really be able to do that much. If it's active, it depends a little bit on how big an area is involved. Is it scarring or non-scarring? And very often early on we'll do intralesional steroids into the scalp or topicals. But if it's in the scalp and it's going to lead to scarring, we're usually going to be starting a systemic agent such as hydroxychloroquine pretty early on.
So you mentioned hydroxychloroquine. Do patients have to stay on hydroxychloroquine long term, or is it like, okay, we're going to put you on this for a few months, and then if your disease regresses, we're going to start to taper you off of it?
Yeah, it depends a little bit on the patient. So in people who have systemic lupus, it's thought that the hydroxychloroquine may prevent progression to more significant systemic disease. So some of those patients, if they have, ANA and they've got arthritis or pleuritic chest pain, you may actually keep them long-term on hydroxychloroquine. There are patients who have bad cutaneous lupus and you can't stop the drug because they will relapse with their skin. And then there are patients where you might cycle on in the summer and off in the fall, and you treat them seasonally. So it really is very dependent on the patient.
Are there any concerning side effects for treating a patient with hydroxychloroquine long term that we know at this point?
Sure. I mean, the patients need monitoring. In particular, the main one is for eye toxicity, which is pretty straightforward. The tests have gotten much more sensitive, and you can normally pick up on any problems before they become a clinical, issue, and then they can stop the medication. That becomes more of an issue after 5 years, where you have to monitor them every year. So we'll get a baseline, and then either every year or after 5 years every year. eye exams. And so there, with longer use and higher, total dose, then there's more likelihood of getting, more eye toxicity. But very often it's worth the trade-off because you can monitor and detect it.
So, other than the eye toxicity, do you have to monitor blood work or any other exams?
So the blood work we might monitor like a month after they started like hydroxychloroquine, and then typically you're going to be following their blood work for their lupus, depending on whether it's systemic or cutaneous. So they don't need a lot of intensive monitoring, but I would say for a stable CLE patient, at least once a year they should have monitoring for their lupus. I don't think the hydroxychloroquine requires that much monitoring.
That's good to know. So, how do you go about treating patients who are refractory to antimalarials?
Right. So, actually, talking about, let me mention one other thing with the antimalarial. If someone's going to start a drug that may cause a prolonged QTC, we do recommend getting an EKG before and after to make sure that they're not at risk of having an arrhythmia related to the hydroxychloroquine. In patients who don't respond to hydroxychloroquine, we usually will consider either adding quinacrine, which is now available again as a compounded but usually not reimbursed drug, and that works together with the hydroxychloroquine to help a lot of patients. And if that doesn't work, then we stop hydroxychloroquine and we can switch to chloroquine. Chloroquine has more eye toxicity, so we have to monitor their eyes every 4 to 6 months, but it is another option. If that doesn't work, usually another thought could be something like dapsone, but that works maybe in half of people by some studies, but there have been good controlled trials. And very typically, we might move on to methotrexate or mycophenolate mofetil for patients who are not responding to hydroxychloroquine or who have significant disease where you can't wait for a couple of months for the medicine to start to work. And then if that doesn't work, then there are drugs like lenalidomide that we will consider using, which are very effective, but they're teratogenic and they require some additional concerns when you have to use that.
Do you find that, not every lupus patient has an autoantibody? So we know that many acute CL patients have antibodies to double-stranded DNA. We know with subacute and chronic CL patients, they have antibodies to Rho. But do you ever find that if you've tested for that specific antibody marker, do you find that the treatment has worked better?
That has not been shown at all. I mean, I think, in general, it's pretty hard to show a big correlation. We know that patients with generalized discoid lupus are more likely to go on and get systemic lupus and maybe be a little more refractory to treatment. But in terms of the actual autoantibody, I'm not aware of any data that suggests there's a difference.
So, could you share with us about any promising therapeutics on the horizon, whether it be biologics, topical JAK inhibitors, which I know atopic dermatitis patients are anxiously awaiting to use, zinc finger transcription factors like CC220, any promising therapeutics on the horizon and what your thoughts are on them?
Yeah, I think there's a lot of it's really the most exciting time I've ever seen in treatments for cutaneous lupus and for SLE. There have been 2 new drugs approved for renal lupus just in the past year, and they also, at least one of them, anifrolumab, is working in skin as well. And there's a lot of other drugs that are targeting type 1 interferons, as well as you mentioned, Aiolos and Icaros. Is a different study. It's actually a derivative of lenalidomide that was studied in SLE, and it probably is going to be working for other subsets such as discoid lupus and maybe subacute cutaneous lupus, similar to what lenalidomide did, but that's still too early to know. But there's other drugs that target PDCs in different ways that also seem to be working. And so this is an amazing time. And we really think it's important to enroll patients in trials so that we can have the opportunity to get new drugs approved that may work better than the ones we have right now.
And do you feel like there's promise with the JAK inhibitor topicals?
I don't think we know that yet. If you look at the one study that was done with the JAK inhibitor orally, it didn't seem to do that much for skin. It worked on joints. And so I think the jury is still out to know if it's going to be effective, or maybe there's a subset of patients with cutaneous lupus where it would be effective, but we just don't have enough data right now.
Have these therapeutics shown to not only improve the cutaneous lesions of the the forearms, the face, but also the scalp?
Yeah. I mean, I think there's evidence that if the drug is effective, that it doesn't seem to differentiate where the lesions are.
Okay. Well, Dr. Werth, thank you for sharing your knowledge with us. Is there anything that you think you could add that I didn't ask you today?
Nope, I think you asked a lot of great questions, and hopefully that was helpful.
Thank you so much for your time. And I hope that everyone who watches this podcast feels like they learned some knowledge about lupus and can walk away with greater knowledge from Dr. Werth. So thank you, Dr. Werth, and I enjoyed speaking to you today.
Okay, great talking with you.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.